So this next technique in the algorithm is, say you fail the needle crack technique or you've chosen to do a surgical technique. Andrew Hurd's algorithm describes the Scalpel Bougie technique. Now, I really like this technique just for its simplicity. You essentially just need 3 pieces of equipment, really. So that's your scalpel, your bougie, and then a size 6 tube. So again, with this technique, I'm standing on the left side of the patient because I'm right-hand dominant. I'm doing that laryngeal handshake, finding out where that cricoid cartilage is and the thyroid prominence, and that's your cricothyroid membrane. I'm doing that hold of the larynx with my thumb and forefinger. And then I'm using my scalpel and doing a horizontal incision on the cricothyroid membrane, just like so. And now at that point, I can point the scalpel down and turn it vertically. You can see that there's a bit of a triangle created, and that's where my bougie is going to slide. So I then swap my hands, pass the bougie along the surface of the blade, and once I'm in the trachea, I can turn it caudal down towards the lungs and push the bougie through. Now, I'm mindful not to push the bougie through too far because I really don't want to cause any trauma down into the airway. I remove my scalpel, put that safely. And usually this is a 2-person technique. You want to be able to stabilize the bougie and then also pass a size 6 tube. And at this point, I can railroad this tube down. So that's heading down. This is again a variation of the cell digger technique that we'll often use for line insertions. And I give a small rotation, and then I really just need to push it down to the black line, just like in a normal intubation. That way the cuff is in the trachea. I then take the bougie out. Once I've taken the bougie out, inflate the cuff. Sometimes you might need more than 5 mils. Just want to make sure there's no leak there. And then connect my Liddell bag. And you can see ventilation there. Of course, I can attach my filter and my end-tidal oxygen to make end-tidal CO2 measurement device to make sure that I'm actually in the lungs. Now, once I'm in the airway with the bougie, the technique describes using a RapidFit connector, and this way I can use this connector, insert it onto the end of my bougie, and clasp it on with this white locking device. So now that's really firmly fit there. This then connects to one of those 15-22mm connectors, which is the standard type connector. And that way I can get some oxygenation in. Now, while this will give you oxygenation faster, using this connector may be a bit slower just because I can't get the same level of pressure. Sometimes these RapidFit connectors have a Lure lock, which means I could connect a jet ventilation device to get rapid oxygenation. Sometimes you may not have a RapidFit connector, in which case you can just use your 14-gauge cannula, insert it like so, and then attach your rapid oxygenation device. And this may provide some level of oxygenation through a jet ventilation device, even though I didn't have the proper RapidFit connector which would sit there. Now, even though that this is the technique that's taught by the Andrew Hurd algorithm, I know that in some situations we might not have a RapidFit device, and I might not have all my equipment ready for rapid oxygenation once I've got the bougie in, and maybe my bougie doesn't have a hole. They're not always going to be this way. Therefore, I may just want to railroad that size 6 tube as quickly as possible to get my patient safe with a definitive airway. I'm now going to show this in one smooth sequence. So laryngeal handshake, making a vertical incision, opening up that triangle, swapping hands, loading the bougie along the blade towards the airway. I can either confirm with I can use the RapidFit connector or just connect my tube straight off. And then railroad my tube, take my bougie out, inflate the cuff, and then put that on.